Good morning. My name is Marta Zaharia. I will be moderating this session today. First, I would like to introduce Moa Wahlqvist. Moa has a PhD in disability science with a background as a social worker. She holds a part-time position as researcher in the region of Örebro County, Örebro, Sweden, and is affiliated to the Faculty of Medicine and Health in Örebro University. Please forgive me if I'm not saying that properly. Moa is she also works part-time as a coordinator at the Swedish National Resource Center for Deafblindness. Her research focuses on health, well-being, and rehabilitation and biopsychosocial context for people with deafblindness and their families. I'm also going to introduce our second speaker at this point. Atul is a trained occupational therapist as well as a rehabilitation social worker with experience of more than a decade in the field of disability rehabilitation. He obtained his PhD in rehabilitation science from Queen's University, while his doctoral thesis focused on identifying ways to enhance the social participation of individuals with deafblindness in society. His postdoctoral research explored the impact of COVID-19 on access to healthcare for older Canadians with dual sensory loss. His research scholarship aims to advance the knowledge in the field of rehabilitation to promote equity, occupational justice, and social participation for individuals with deafblindness. Welcome.
Thank you, and thank you for the opportunity to present to you here today on this rather small project that I've been conducting as a consequence of the corona pandemic. Questions rose about how do people with deafblindness access information, and how accessible is the information, both when it comes to content and format. So I applied and got some funding for a project on accessible information for persons with deafblindness during the corona pandemic. And the aim, maybe I was a bit naive, we'll see, but you have to maybe think big. But the aim was to develop guidelines for making information from responsible agencies in society in Sweden accessible for individuals with deafblindness in times of crisis. And in Sweden, we have several agencies that are responsible for providing information. So at that time, during the pandemic, there was a lot of information coming out from different sources. And some of the information was the same, and it could also differ depending on what agency, if it was information on to the whole society from the government, or if it was more a locally distributed information from the municipality or from the region where you were living. So interesting to know for us was, how do you navigate in this system? But we also wanted to know from these agencies, what do they know about making targeted information to a certain group, in this case, persons with deafblindness. Do they have the resources? Do they have the possibility to do that or not? So that was some of the questions we were elaborating on. On this next slide, I have the method. We used a mixed method design. We constructed a digital questionnaire that was sent out to persons with deafblindness in the member organization in Sweden. So I worked in close collaboration with them, both in developing the questionnaires, in content and in distribution of the questionnaires. They had contact information to the members. This was an quite complex thing to do, but it was also interesting because we used a platform that was already for questionnaires, for digital questionnaires, that was already in use and is the one that they recommend for us researchers to do at the department where I work. So we were a bit restricted to use that one, but it was also interesting to see, would it work? Because from the department they say, this is accessible, anyone can use it. Okay, let's find out. And then I've done 10 interviews with office holders at authorities with the responsibility of providing information during the pandemic. And the question to them was more like, what is your assignment in relation to giving out information in times of crisis? What are your resources when it comes to giving out information? How much can you target to certain groups? And if not, what do you do? And what ways do you have to communicate the information? In the process of developing the questionnaire, as I said, we worked closely together with the member organization and with other experts at, for example, the resource center to find out, are the questions feasible? Can I access with different kinds of devices? If I use my phone or the computer, can I read the questions in the questionnaire with a Braille script reader and so on? And it was not perfect, like we would have wanted in the best of worlds, but it was working. One can say that some of the difficulties that people had when accessing the questionnaires were related to coding of the platform, or how the platform dealt with questions and answers, and if there were multiple answers and so on. How was it structured when you use a Braille script reader, for example, or so were there headings or not, and things like that. So there I worked together with one of our technicians at the department to try to find solutions to make it even more accessible. As I said previously, the member organization in Sweden, they helped us to send out the questionnaires, and we did that. We did our first sending out with some small information about what it was, what we wanted, and how they could access the questionnaire by using a link and so on. And then we repeated this twice. We also encouraged people that wanted to participate but maybe could not use the link and could not access online to be in contact with either the person at the member organization or in direct contact with me, because then we could provide the questionnaires in a different format. So there were also examples of people taking contact and where we sent out the questions in Braille or in large font on paper. And we could also provide help if someone wanted to answer writing Braille. I could have help to interpret that to text, because I don't read Braille. So we tried to the best that we can to adjust. I don't have the exact number of how many participants with deafblindness or how many members in the organization that have deafblindness. Somewhere around 400 is the figure that I have. We have 59 answers, so it's a small group, but still. The mean age of those answering, sorry, I'm supposed to change picture to the preliminary results. The mean age was 57, and we have an age range from 15 to 86. More women than men answered the questionnaires, 61%. It was evenly distributed between if you were living alone or if you were living in a family. And we also asked, do you have children, and who do you live with, a partner or someone else? Different ways to communicate is represented. Both spoken language, visual language, and tactile sign language. Yeah. And we have different levels of education and so on. So we think even if it's small, we have a wide distribution of people who have answered. And what do they say? Well, many of them report that the first information that they got about the COVID and the COVID pandemic was through media or social media. Watching TV, listening to radio, stuff like that, using Facebook. But some also say that it's not possible to access that way. You need another person to tell you what is going on. And for those who have access to information, that can use their devices, that have this knowledge to do that, and know where to find information, because we have people say that, I know where to find the information, but still there are challenges. Can I trust the information if it's in social media? Or even if it's from the agencies, can I trust the information? How can I know that it's the latest, or where does it come from? Who says? But there are also stories of too much information and difficulties to search for information, and delays in the information given. Some people received information in Braille, and that was delayed about a week. So when you got the information, it was a week later. What has happened during the last week? And when you got the information, it was not structured in a way so it was easy access. You had to read all through all the papers that you got, so it was exhausting. People also describe challenges with new words and concepts that can be difficult to comprehend. All these medical terms that were used, and what is flattening the curve and stuff like that. How can I understand that? If I watch TV, in Sweden we have broadcast every hour from the public health agency and from the government, and they were sign language interpreted, not in the beginning, but after a couple of weeks. But if the interpreters were too quick, it wasn't accessible. Someone said, I had my partner to recapitulate what was said. And what about the future then? Yeah, people express that they want one place to go to. Don't have to search around finding information yourself. And they also suggest that the social services, healthcare services, the deafblind units that we have in Sweden should be the one that were responsible for providing information. So they would condense the information, make sure that it's accessible, and then give it out because they know who we are, as some person wrote to us. So that was a wish for them. For the office holders' experience, they said this is a process of learning. So in the beginning of the pandemic, they didn't know much about how to gather, spread information, and so on. And they didn't have ways to be in contact with the target group. And some also said, we don't have that assignment. We are supposed to give general information to the general public. We don't have that. We would like to, but how can we get in contact with a member organization, or who should we contact? But they also described a situation of learning. We have learned a lot. We have learned both to collaborate between agencies, and we have learned to collaborate with different groups in society. And finding, in that way, new paths for collaboration. So to wrap up, what recommendations can be given? Yeah, $1 million question maybe, and as I said in the beginning, maybe I was a bit naive, but still I think there are recommendations that can be given, maybe not on a very detailed level, but still. One is that it should be so that support providers need to accommodate for persons with deafblindness to have access to information in their preferable way. That could be solved, but of course knowledge is needed. And authorities need better working models to adjust and provide tailored information to persons with deafblindness. Today, or at that time, they didn't have knowledge to, for instance, there were films with information in sign language, but there was no one to control if it was understandable. So it was just an interpretation of what's being said, and that's it. And then the office holder said, yes, but we provide in different formats. Yes, but that is not enough. That doesn't mean that it is accessible. So hopefully this is something that we can work on further on. Yeah, thanks for that.
Thank you. I'm sorry that it felt a little rushed, but we're going to welcome Atul up to the podium now, so thank you.
We can have questions together, because, yeah. Thank you so much, everyone, for coming here today. So I'm here not as a researcher. I'm here as a person who is advocate with respect to using research, conducts research, and uses research as a tool for change. That's what we would like to see in the world of deafblindness. So this particular the presentation that I'm talking about is about coming from my postdoc work that I did with Dr. Walter Wittig and the rest of the team here. I would like to acknowledge the land of where I live. It's traditional homeland of people of Anishinaabe Algonquin Nation. I would like to acknowledge the support that I got from my funders and research partners. Some of them are here. I'm sincerely thankful to all of you because of you, the study was possible. So we all know about deafblindness. I think I would not go and define what it is. I think I would rather use this opportunity to talk about the point that people often think deafblindness is a low incidence condition. I would argue like that we have to stop thinking like that first thing. It's a quite a big number that you're talking about here with respect to in Canadian population itself. We are talking about 1 million people. It's quite a big number. So if we put the global context, it's further big number. So I think I would like to change the whole dialogue. Like we should stop saying it's a low incidence. Okay. So we know the stories, what happened to us during COVID-19. We know how it how COVID-19, the pandemic impacted us and our loved ones. So I think my whole inquiry was to understand what is happening to our older Canadians who are here, who are trying to access healthcare and rehab during COVID-19 because of the use of masks, because of the physical distancing, because of all other sort of restrictions that were put in place during COVID-19. We all know that they are at high risk of cognitive impairment, functional decline, social isolation, like all of these things are sort of we know about it. But then how everything changed during COVID-19 because of all the changes that happened very rapidly. So I think that's what was the line of query that I wanted to explore here. So this was all about understanding the continuum of care for older Canadians with dual sensory loss or deafblindness during COVID-19 in Canada. So I had 4 studies. First one was systematic review that we did to understand what evidence exists out there with respect to what tools and strategies are out there to help provide continuum of care to our older adults with deafblindness. So that particular study led to like a little bit of understanding of 7 tools and 7 strategies that were out there. I would not go, but that for sure, that systematic review informed our next further study that we did in this work. The first study was qualitative interviews with older Canadians from Quebec and Ontario. These are the 2 provinces here. So pretty much if you put the 2 population together, it's approximately, I'll say, 60% of the population is covered in these 2 provinces. So that's what we did here with our team members' help. And then we conducted, so there was 32 interviews were conducted with older adults and 32 sort of people participated in focus group discussions. So I wanted to understand the stories of people who have deafblindness, like older adults with deafblindness, their story, and then also wanted to understand the story of caregivers, like family members or support providers who were there with them in this journey of accessing healthcare. That was the story. So that's what we captured through this study 2. Study 3 was trying to understand the stories of or lived experience of healthcare providers, because it will be like a missing piece of the puzzle if we don't understand what is happening to healthcare providers during the time of COVID-19 in providing care to older Canadians with deafblindness. So we did an online survey with 229 healthcare providers, and then finally I asked those healthcare providers if they are willing to share more of their story, details. So then out of those 229 healthcare professionals who participated in this study, 22 of them agreed to share more data, share more stories, right? That what happened and what worked, what did not. So that was that part. So today I'm taking this because again it will be too much to present all of this in 10 minutes. So I'm basically going to give you a snapshot of what I think you need to take away from this session today. Yeah, I think most important findings. So existing challenges in continuum of care. So I think I'll start with the first point is client-provider communication. So communication, we all know how critical it is for deafblind individuals. So communication, healthcare communication between the care provider and them was the most challenging aspect. And we all know how, I'm pretty sure, though I'm talking about all these challenges, you could relate to your own work. You have seen those challenges during pandemic. So it's nothing new, but if you ask me a specific question, I can give you more examples there. Then lack of training, time and comfort. I think healthcare providers, they had lack of time. They have a very tight schedule. They have to fit everyone, and then they might not know this particular older patient who is coming to see them. They have dual sensory loss going on. So they were not prepared for that. And then they have to squeeze in whatever best they could do. So that's what was happening. And then they also were not trained how to communicate with them. Because if they are not aware of the accessible format, if they are not aware of the different healthcare communication, like how to communicate with like individuals with deafblindness, because every person is unique. Every person who with deafblindness is unique with respect to their communication. So if they are not aware of that, it's going to be a bit of a challenge for both the parties. So that's what was one main thing. Lack of, again, then the comfort. Comfort, the moment the person enters into the clinical setting and then they see, oh, this particular person is difficulty using, like sort of difficulty communicating with me, what's wrong? And then there was a mask in place, there was a plexiglass in place, and then there was a little bit of physical distancing also in place. That like complicated the whole scenario. Environmental accessibility. So that was another important aspect, because people assume that you know how to go about an hospital setting or a clinic, right? I think we need to change that whole conversation, that how can you assume? You better ask the person whether they have understanding of how to go about from one place to another within the clinical setting. That was not considered. That was one main thing that came out. Telehealth. Telehealth became one main thing during COVID-19. I'm a strong proponent of telehealth, but how it was suddenly imposed to all of us, that was not good. Without considering the challenges or the considerations that need to put in place for older Canadians who have sensory loss, that was I think not considered, and that led to a lot of challenges, because we know that they're like congenital deafblindness and people who have acquired deafblindness or advantageously deafblind, right? So stories are a little different. People who have seen this world, like the world designed for non-disabled population before COVID, during COVID-19, their challenges obviously changed a little bit, but not to a lot of extent. But for people who had acquired deafblindness, suddenly their world changed. Their social networks, like social support circle changed. The people who were helping them before COVID-19, they were not there anymore, because everyone was trying to remain in their own social bubble, which is safe for them. There was a fear of touch. People do not want to touch. So all these sort of things were complicating the whole scenario. And within that, telehealth was introduced. So it was a bit of chaos there. Limited caregiver support. I was talking about healthcare accompaniment. People were not aware that how crucial it is for a person with deafblindness to have someone with them as a healthcare accompaniment when they are going and seeking services. Having an intervener, having a family member, having a friend, having a volunteer is very important. Though they might not play a big role in communication, but they are there to help. They are there to navigate. But suddenly during COVID-19, restriction, sort of obviously visitation policies changed, healthcare accompaniment policies sort of also were regulated. So not everyone can go, only patient will go. And then it was a bit of a challenge for all those people. And then inaccessible health information that I think Moa just talked about. The access to information is so critical. Public health guidelines and information was just rolled out without thinking whether it is reaching to audience with deafblindness at the right point of time and in the right way. So that's what the main challenge is that I think but I'm happy to talk about more, but I think I'll with respect to time, I'll restrict myself here. The most important stuff that I want you to take away, and I would say that it's not coming from, this is coming from research, but I think I want you to advocate. I want you to advocate whenever you get a chance to see and sort of to speak about deafblindness and to speak about healthcare with respect to deafblindness. I think I want you to take away these 4 things. So the first thing, accessibility of clinical health setting and health information. That's first and foremost, and I think Moa's talk already talked about the importance of access to information with respect to our people who have deafblindness. So I think healthcare and deafblindness, I think a lot has to, we need to do a little bit more with respect to our research work in the space of healthcare access and rehab care access. So I think that's what would be one main thing that I want you to advocate, that whenever you get a chance to see or you are with a person with deafblindness, you really sort of tell the person that this particular setting is not working well for this person, or maybe there's a system put in place to ensure that the person is prepared before they went into this clinical setting, that how to navigate this building, how to navigate this clinical setting. Where would be a doctor, where would be a reception? All these small things, but that matters a lot for people with deafblindness. And then health information. Public health information was changing rampantly, and over the period of, we all know how it was changing so fast, and then maybe those information, if they were not given, that when you can allow someone to come in and when you cannot, when people are not allowed, I think things were changing very drastically, and if that information is not reaching to our clients with deafblindness, that was a very big, I think, challenge for both parties. Reliable healthcare accompaniment. I think we should advocate for this point that older adults or people who have deafblindness, when they are going and accessing care, you should allow them to have a healthcare accompaniment. Okay, yeah, sure. And then finally, training on dual sensory loss specific care. I think the more we communicate about deafblindness, the more we share what we do here, like what we do in this space of like deafblindness work with others, the more people will get aware. Doctors, nurses, pharmacists, I think all of them need to know about deafblindness and dual sensory loss and how people communicate. Asking like first question should be, okay, do you have sensory loss? And then if you have sensory loss, how do you communicate? What is your preferred way of communication? I think these are some of the important things that people need to consider. So a lot of training has to happen, or training needs to take place. And then finally, we know that how technology play a crucial role. So use of aids and assistive devices. Pocket Talker was a very big savior. iPad was a very big savior. No one thought of those technologies, but they were used in long-term care homes. They were used in different settings when people were accessing care. So, and that worked, but no one thought. So maybe now people will start thinking of using technology when they are providing care. And they're like using small, like a lot of simple things could work. But whether people are putting like that understanding in place that how I can provide best care to this older patient who is coming and seeing me here. So these are the 4 important things. And then finally, with conclusion, I would say that like we need to do more with respect to research, and we need to advocate. Whenever we get a chance to, we need to talk about deafblindness, the challenges, unique challenges that these individuals have, and then how we can be alive, how we can change the system down the line with our advocacy. So these are some of the references. You will say that I'm saying myself as an advocate, but I'm not doing anything except the research. So this is what I'm doing right now. So for me, I'm having a mission that I would really want to see that rehab professionals and healthcare professionals are aware of this condition, are aware. So that's what, so on the right-hand side of the screen, you will see that there's a task force at American Congress of Rehabilitation Medicine. The membership is more than, I'll say, 100,000 people, like rehab professionals across the globe from 65 countries. So I'm leading a task force there. It's called Integrating Sensory Health and Rehabilitation and Aging Research, because I believe for older adults, we know that older population is changing here, and we really need to advocate more for them. So that's what I'm doing, and you are happy to join and collaborate and help me and help everyone else on the task force to advocate and bring that change, so that people whenever they see an older patient walking in their clinical setting, they need to think of sensory loss as one of the main things that they should consider. I'll stop here. Thank you so much. If you have questions, I'm happy to take it later.
It's not often that you get a second try to try to stick to time, but thank you again for giving me the opportunity to talk to you about adults with deafblindness. What are their supportive needs to live the life they want? And it's Moa speaking. And I also want to say that I have 2 collaborators in this study that we did, and that is Agneta Andersen Karlsson, who is also here at the conference, taking care of the baby right now, and Emma Varga, who is a social worker at the deafblind team of rehabilitation and health in Örebro County, where we come from. And Emma, just like me, has grown up with sign language in the family, so that has been to a great help when we do our interviews that we have done in this study. So for the background, persons with deafblindness need lifelong support to be able to be active and involved in their everyday life. If support is not provided, the results might be negative, resulting in physical and mental illness and social isolation. This is described in research, and I also think that we have that from professional perspectives and from the lived experience perspective. This study that we did was a part of a larger project to explore support given to adults with deafblindness living in Sweden. And it was an initiative from the Swedish National Resource Center for Deafblindness. So in total, this project includes 4 different parts. One was a mapping of the support given from rehabilitation settings, deafblind units, all across Sweden, all 21 regions. Asking professionals what resources and so on that they have to provide support. It was this study I'm going to tell you about, and it was also a scientific review of published articles concerning support and interventions. Are there any that are validated and so on. And then there was a review of the more professional perspective on what interventions, methods can we find that are described in what we call grey literature. So that was the project in total. But I will talk about the interviews that we did. And the aim was to explore the needs of support for everyday life as described by adults with deafblindness. So just an initial question: what support have you been offered? What are your experiences? What are your needs? And have the needs been met or not? And elaborating on that. We have done interviews, both individual or in focus groups. So we did, in total, 16 persons has participated, 11 women and 5 men. We did 2 focus groups that was with persons who use tactile sign language only. And then the individual interviews have been different. And the interviews have been audio or video recorded depending on which way the person uses for communication. And they could also choose if they wanted to have an interpreter with for the interviews or if they wanted a direct communication. Then we have transcribed all the materials from the interviews, and we have used a way to validate the interviews in sign language, where Emma and I have worked together looking at the videos, transcribing and looking at the videos again, trying to capture what is the intent of the person, that the person tells us. And we've used a thematic analysis to see, to organize and analyze our interviews. So, the superordinate theme that we could identify was the importance of being treated as the unique individual that I am. And this runs like a foundation through all the other themes that we have found. And it was one person that said that the knowledge of the professionals needs to be greater than mine, but they still need to encounter me with where I am, with the needs that I have. All people with deafblindness, we are not the same. So knowledge is needed. And so that was for the superordinate theme. And then we identified 9 sub-themes. And one of them relates to this knowledge, and that's my own knowledge as a person living with deafblindness. I need to know at least my diagnosis, the prognosis, my rights, in order to be able to orient myself within the healthcare system, or what can I ask for, and so on. But they also talk, I need knowledge because sometimes I have to solve things myself. There is no one to help me, so I have to have the knowledge. They talk about different kinds of aids, both for vision and hearing, but also not so much, but a little about tactile aids. One woman, she talked about a scale that she had before, but it wasn't there any longer. It was tactile, so she can know her weight. but now there wasn't. And she missed that one. She wanted that. But they also said that the mobile phone was the one device that I used the most for everything, for keeping in contact, for paying bills, for making reservations, and so on. So that was one of the most important aids. Training and support to use the aids that you have was also something that they had experience of and needed. And most often the need wasn't met. They needed more training, more support, more follow-ups. When I have received, for instance, someone talked about a red and white cane, you get initial training, but the follow-up is not sufficient. Adjustments of the environment mainly dealt with lighting, different kinds of lightings at home. And also here the experience was that you could get help with that, but maybe you only get adjustments of lighting in your bathroom or in the kitchen, but I need to go up to the attic. No, that's not possible. So not being met with the need that I have. People talked about equal support and knowledge in the society, and that was, when they talked about that, they said that, okay, I live in this part of Sweden, and then I meet with my fellow persons with deafblindness, and they say they have received this kind of support or this aid, and I want that too, it sounds great, I think it would work for me. And then I go back to my deafblind unit and say, I want this. No, you can't have it, we don't have that here. So they identified an inequality in the support given and the lack of knowledge in society about deafblindness. And here they also expressed like the resource center or that the deafblind units have an important function to fill to give knowledge and information. Family support was addressed. One woman said, I'm not by myself. I live in a family, so I'm not the only one who has problems with deafblindness. I know my deafblindness, but my family, they don't. And also here there was experiences of, my family needs support. When we ask for support from the deafblind unit, they say, okay, no, but we can only give support to you as a person, not to your family. And turning to a family unit, they say, we don't have the knowledge about deafblindness, we can't help you. And not meeting the need. Moving on, they described two social services that they received support with for transportation or guides, interpreters, and so on. And also here it was both, I get it, but not as much. So it comes back again and again. And much of that goes back to this, I want to be met in the situation with the individual that I am in the life that I live. Practical support was mainly given by peers, but also from deafblind units in learning new skills maybe, or where to change my Braille script reader or something like that. When it comes to emotional support, this was something that they also got or received from their peers, learning from the ones who were a bit further ahead in their processes. And when it comes to receiving support from rehabilitation deafblind units, counselors, psychologists, and so on. One woman said, counselor or psychologist, I've tried many times, but communication don't work. And one counselor, she felt sorry for me, and I don't want to hear that. I want help and support, but there is none. There were also stories about this, I want to have emotional support in my language with someone I can talk to directly, but there isn't. I know that there is in a different unit, but I can't go there because it's only for deaf people or hearing impaired, and then I'm not allowed to get help from there. So, to conclude, tailored support is needed. We have tailored support in Sweden today, but it's needed to a greater extent and even more individualized. People want to be met by interested, knowledgeable professionals, asking about my life and my situation. And the whole life situation needs to be considered. I'm not an island, I live in a context. And things change over time, so follow-ups is needed. So with that, I say thank you for the attention.
Thank you so much. It is 11:45, so we are supposed to be moving on to the next, but I'm sure if anyone has a question, we can accommodate for a couple of questions. I'm going to bring the microphone over. Yep.
A question for both of you. In Australia, we're beginning a process of looking at the COVID pandemic and looking forward to disaster preparation for the next pandemic or the next big disaster. What would, from both of you, what would be your take-homes from the things that we need to do in disaster preparation for older care as well, and for information dissemination and more for people with deafblindness, dual sensory impairment? The things that we can do, the things that we should be doing now.
Yeah. So this is Moa. In Sweden, we had the pandemic, and then it was a lot of awareness about what is needed and how can we do, and there was this force to do something, and then came the war in Ukraine, and then the awareness was still there, and I think that was. It's not good that it was a war, but it kept the discussion ongoing. And now we can see that the discussion is a bit fading. But I know that there are this discussion within the association, within the member organization, how to be prepared. They have things, they have seminars around that. How can you prepare yourself? And what do you need to know? So that is one thing. But then I think for the authorities, it's just to keep on keeping them aware of people with deafblindness. Otherwise, it will go into this mass of whatever. So I think it's more of an awareness work. Yeah.
I'll just add to. So when I think of disaster and disaster preparedness, I think of two things: natural disaster, which is we all know flood and everything else, earthquake, and then we have biological disaster like COVID, right? Which was a very different beast altogether. So I think we need to come up with a strategy for those two types of disaster preparedness. The first thing that I think we need to do is also advocate and reach out to those national disaster management authorities and tell that what were some of the unique challenges that these individuals with deafblindness face during COVID-19, or even whatever, if we can generate some evidence on the previous experience, we should sort of collate all that in a small 2-page report, nothing more than 2-page report, otherwise it will be just one report, no change happening. And then it should be communicated in a right way that what are some of the exact steps need to be considered. And if that happens, I believe the next disaster, whenever it will happen, will be better prepared. I think the key message that we need to give it to them is, let's have the people who are last in the line to be put first in the line. I think that has to be the whole communication that needs to be given. If that is not communicated properly, again, it will be an afterthought always. And I think that has to change. Anne-Marie, I thought I answered. Okay.
Well, thank you to you both. It was a great presentation. I do have a gift for you, of course. So that's for you.
Thank you.
And that's for you. Thank you so much.